Okay, I think we can get started with this session. That's right. So, um, introductions and then get moving with the questions, and we will end on time, if not a little early, hopefully. So this is Disorders of the Liver, session 2. Um, and we are, this is the list of our faculty today. So Amanda Chung is a clinical assistant professor and transplant hepatologist who is based at our Emeryville location. Tammy Doherty is a clinical associate professor and transplant hepatologist who heads our living donor program and the transplant program at Renown in Reno, Nevada. Renu Dhanasekaran is an assistant professor whose research in liver cancer has been funded by Career Development Awards from the ACG and NIH. Deepti Chonamraju is obviously our esteemed course director for our co-course director for this board review course. She's a clinical assistant professor and transplant hepatologist who heads our liver disease and transplant program at our Valley Care location in Pleasanton. And Aparna Goel is a clinical assistant professor and transplant hepatologist with a specific interest for this course in autoimmune and cholestatic liver diseases, although that's just one of several interests, I think. And I am Allison Kwong. I'm also one of the transplant hepatologists here at Stanford. So we can start with the questions. The polling system and setup and Q&A is all the same as the past couple sessions, so hopefully you are familiar with the way things are set up. So we'll just get started here. A 27-year-old man with newly diagnosed well-compensated cirrhosis due to primary sclerosing cholangitis presents for initial consultation. His past medical history is notable for ulcerative colitis that is well controlled with mesalamine. He feels well and has no specific complaints. His AST, ALT, total bilirubin, albumin, INR, and platelet count are all normal. His alkaline phosphatase is elevated to 347. Which of the following do you recommend for further management of this patient? Liver biopsy to grade and stage his PSC, ERCP to assess for progression of his biliary strictures, annual ultrasound evaluation of the gallbladder, initiation of ursodeoxycholic acid at 30 milligrams per kg per day for colon cancer prevention. You should see the options on the poll everywhere, but you've got liver biopsy, A, liver biopsy, B, ERCP, C, annual ultrasound, or D, ursodeoxycholic acid. I think we can see that. Let's see what we've got here. Okay. So you can change your choice. All right. Aparna, I think you're up for this one.
Yeah, so 2/3 of everyone got this right. So this patients with PSC are at risk for gallbladder cancer. And the lifetime risk is still not as high as that of cholangiocarcinoma or colorectal cancer. So it's about 1 to 3% lifetime risk of gallbladder cancer. So an annual ultrasound of a gallbladder is recommended. The risk for cholangiocarcinoma, the lifetime risk for cholangiocarcinoma and colon cancer, especially in a patient that also has ulcerative colitis, is much higher than that. In terms of the other answer choices, so a liver biopsy in this patient is really not necessary. It's already been established that they have cirrhosis, so getting a biopsy won't really provide any additional information to guide your management. An ERCP and PSC is warranted if you're worried about bacterial ascending cholangitis or if you're worried about a cholangiocarcinoma. But just for the sake of diagnosing or staging PSC, it really does not add additional value and may actually be harmful to the patient to do, as the contrast sometimes serves as a nidus for infection in these patients. So in the setting of pretty stable PSC without specific concerns, we wouldn't pursue an ERCP. And then lastly, ursodeoxycholic acid. hasn't really been shown to impact the natural history of PSC, especially in more advanced stages of diseases, F3, F4 disease, so more advanced fibrosis, and at doses higher than or doses at 28 to 30 milligrams per kilogram, that there's actually a higher risk of mortality in these patients. So high doses of ursodiol should be avoided in all patients with PSC. If you go, yeah, the review on the next slide just talks about the overall screening management that we do for our patients with PSC. And someone that has cirrhosis, their risk of hepatocellular carcinoma still exists. So we do Q6 month screening, just like anybody else that has cirrhosis, with cross-sectional imaging ideally. The gallbladder cancer we talked about, so a yearly ultrasound is recommended, and a cholecystectomy should be performed if a polyp is over 8 millimeters in size, as those tend to harbor more adenocarcinomas. Cholangiocarcinoma, so the risk of cholangiocarcinoma in a patient's lifetime, that in a patient with PSC's lifetime is about 20%, which is quite high. So it is recommended that we do at least annual MRIs with a CA 19-9. And the risk of colorectal cancer in someone that also has IBD is about 20 to 30% as well. So in anybody that has both PSC and ulcerative colitis, a yearly colonoscopy is recommended.
Aparna, I feel like this comes up every year, but if you're doing the MRI, do you still have to do the yearly
So
ultrasound?
that's a very good question. So the guidelines haven't been updated yet, but our radiologists at Stanford will call you and they'll say the MRI is pretty good at detecting small polyps and definitely will detect polyps that are over 8 millimeters. So our radiologists do not recommend anymore that you get the ultrasound in addition to the MRI, because the MRIs are high quality enough now. The technical guidelines, though, haven't been changed yet to take the ultrasound out for annual screening. So I think that if you're at a place where the radiologists feel comfortable with the quality of the MRIs in terms of detecting polyps in the gallbladder, you probably don't need to get the ultrasound in addition to the annual MRI. But if you are having difficulty with higher quality MRIs, or if for whatever reason a patient can't tolerate MRIs as well and isn't necessarily getting them routinely, then you still should be getting the ultrasounds.
Okay. Or if you're taking your GI boards.
Correct.
All right, thanks. So we'll move on to the next question. So a patient is referred to you for management and follow-up of recently diagnosed compensated cirrhosis and no history of GI bleed. As part of the workup, you obtain an upper endoscopy. This looks normal without evidence of varices. Which of the following is the next best step in management? A, obtain portal pressure measurements. B, non-selective beta blocker. C, PPI. D, EGD in 2 to 3 years. So, compensated cirrhosis, portal pressure measurements, non-selective beta blocker, PPI, or endoscopy in 2 to 3 years. All right, I think we can look at our options here. I like seeing those numbers change in real time. Okay, I think we're good. So Amanda, I think we can.
Okay, so no one picked portal pressure measurements, but which is not the correct answer. But they can, if you happen to have them, they can prognosticate or determine the likelihood of developing varices. So usually at 10 millimeters of mercury, you'll develop varices, and at 12 millimeters of mercury, you're more likely to bleed. The non-selective beta blockers are indicated for primary prophylaxis in somebody who is found to have varices, but it hasn't been shown to prevent the formation of varices. So in this patient that doesn't have any varices on your screening endoscopy, you wouldn't start a non-selective beta blocker quite yet. And then with the normal endoscopy, there's no role for a PPI in this patient. So for this question, asking about the appropriate management of a patient that does not have any varices on your endoscopy, the correct answer is D, to do an EGD in 2 to 3 years, as long as they don't decompensate within that time period.
Awesome, pretty straightforward. Great. I think we can move to the next question. So, a 32-year-old woman with a history of hypothyroidism presents to the ED with a complaint of fatigue and jaundice. Her exam is remarkable for moderate right upper quadrant tenderness on palpation. Laboratory test showed white count of 11, hemoglobin 11.1, platelets of 100, AST 131, ALT 155, alkalis of 109, total bilirubin 4.1, albumin 3.0, total protein 8.9, and INR 1.2. Ultrasound shows normal gallbladder with no stones, pericholecystic fluid, or gallbladder wall thickening. CBD of 3 millimeters, liver small size with nodular contour without liver masses. Doppler study shows normal flow in the hepatic and portal veins, moderate splenomegaly, ANA is 1 to 2,560. Which of the following therapies would be a component of the initial treatment of this patient? Azathioprine, cyclosporin, ursodeoxycholic acid, tenofovir alafenamide, spelled with an A, two, has 3 A's, cyclophosphamide. All right, so your choices are azathioprine, cyclosporin, ursodeoxycholic acid, tenofovir alafenamide, and cyclophosphamide. Can look at the answers now. All right. So this looks like an autoimmune question. Parna, you are up.
Yeah, definitely. Definitely a patient with autoimmune hepatitis. So just, we'll talk about some clues that kind of give it away, but just remember that autoimmune hepatitis, the things that, you sort of are worried about, or just sort of clue you into the diagnosis are elevated transaminases, positive autoimmune serology. So this patient had a positive ANA, and then you're not given, I think, immunoglobulin levels for this patient, but you might be on the boards. And if the IgG level is high, or total protein was high here, so maybe there was a globulin gap as well. Yeah, there's a globulin gap. So you do see that there's elevated elevated globulin, so that sort of points to potential autoimmune disease as well. So the other things that in her history that make her higher risk of having autoimmune hepatitis compared to other diagnoses are her gender. So she's female. There's about 3.5 to 4 to 1 female to male ratio for autoimmune hepatitis. And then her history of hypothyroidism, so another autoimmune condition that sort of clues you into potential autoimmune hepatitis. And just remember that patients with autoimmune hepatitis can present along the spectrum of liver disease. So they can present with asymptomatic transaminase elevations to acute liver failure, or acute hepatitis with symptoms including jaundice and arthralgias and whatnot. So this patient, as she's presenting, appears to have cirrhosis, with her platelet count being low, with the albumin being low, and her ultrasound showing some splenomegaly already. And that unfortunately, cirrhosis is present in about 1/3 of adults that are presenting for the first time with autoimmune hepatitis, and about 50% of children that present with autoimmune hepatitis. So a biopsy would be warranted in her, but that's not what this question's asking you. This question's asking you what the first course of treatment is going to be. So there's 2 potential options for treatment for someone like this. One is to only use steroids up front and to see how they respond, so prednisone or prednisolone. And the other one would be to do a combination of azathioprine with steroids. And doing the combination allows you to use lower doses of steroids and potentially save some of the or reduce some of the steroid side effects of the steroids over the long term. This is not applicable for this question, but in a patient that does not have cirrhosis, budesonide would potentially be an option as well. But in a patient that has cirrhosis, we would not be offering budesonide as a treatment option. And then some of the other options that are listed here could potentially be used in patients. Actually, just one other option could potentially be used in patients that fail therapy. So don't respond to first line therapy, meaning don't respond to steroids alone or steroids plus azathioprine. So cyclosporin is an option if you have an incomplete or if you feel a failure to respond to first line therapy. Ursodeoxycholic acid has no role in the management of autoimmune hepatitis. There are patients that have overlap disease with PBC, and you sometimes have to add therapy for PBC. And then tenofovir, obviously, for the management of hepatitis B, which we're not concerned about for this patient. And cyclophosphamide, I think they're just trying to throw you off with a name that sounds like a calcineurin, but it's not really. So a chemotherapeutic agent would not be the appropriate answer here.
All right, thanks, Aparna. This was pretty straightforward, I think, too. All right, can move to the next one. A 50-year-old man presents to the ED with hematemesis and melena. He reports frequent episodes of abdominal pain. He drinks approximately 1 pint of whiskey daily and has done so for more than 20 years. His exam is remarkable for epigastric tenderness. Labs show AST of 105, ALT 60, alkaline phosphatase of 110, total bilirubin 1, albumin 3.8, INR 1. Right upper quadrant ultrasound shows normal gallbladder without gallstones, pericholecystic fluid and gallbladder wall thickening. CVD was 3, liver mildly enlarged with no liver masses seen. Arbor scan shows F2 fibrosis. EGD reveals large funded gastric varices without esophageal varices. What is the most likely cause of his varices? Portal vein thrombosis, splenic vein thrombosis, hepatic artery thrombosis, hepatic vein thrombosis, or sinusoidal obstruction syndrome? This question always gets me because it looks like you got a FibroScan in the ED, which doesn't seem very realistic, but maybe you've got one like the week before in the office. All right, zoom out. So your first 4 options are some kind of vascular thrombosis, portal vein, splenic vein, hepatic artery, hepatic vein, and then sinusoidal obstruction syndrome. Okay. Take a look. All right. Excellent. Splenic vein thrombosis is the, okay, yeah, so we can go into why. Let's go back to the stem. We can take a look at why. So I think GI Boards loves this question because it's kind of it's a liver question, but more of a GI question. So it covers a range of possibilities, and so this is splenic vein thrombosis or isolated gastric varices that's without really much evidence for cirrhosis or liver disease. So where's the problem? So this is splenic vein thrombosis seen usually in chronic pancreatitis or after a pancreatic surgery. And so they give you a history of someone who drinks a lot and has frequent episodes of abdominal pain. So that suggests that this patient has either a history of recurrent acute or chronic pancreatitis. So that's what they want you to recognize. Treatment-wise, the non-selective beta blockers extrapolated for portal pressures and variceal bleeding is a good first step for prophylaxis. In the acute setting, maybe if they've bled, then these can't be banded, but maybe you can glue if your center has glue. If they have portal hypertension or like cirrhosis, since many of these patients also have a pretty significant alcohol history, you could consider something like a TIPS, and if IR is at your center, it can also offer BRTO or balloon occluded retrograde transvenous obliteration. So there are a few tricks IR can try to do if these bleed, but we don't, other than beta blockers, there's not a ton we can do when we can see when we see this entity. But what this question is asking is essentially to recognize this patient doesn't have the FibroScan you got shows only F2 fibrosis, not F4 or cirrhosis. So the cause of the varices is not cirrhosis, it's something farther down the line than this problem in the splenic vein. As far as the other questions, he could have a portal vein, or other options. He could have a portal. It could be an issue in the portal vein. In theory, although he doesn't have cirrhosis, so that's which is the major risk factor for portal vein thrombosis. So that's less likely. And then hepatic artery thrombosis, no reason he would have a problem in the artery. Hepatic vein thrombosis, they're getting into Budd-Chiari, which wouldn't cause necessarily isolated gastric varices. You would see other signs of portal hypertension. And then the last option, sinusoidal obstruction syndrome, will show up later. That's just a distractor. Okay. Next question, unless there are other questions, nothing in the Q&A yet. All right. So a 24-year-old woman is 34 weeks pregnant and seeking prenatal care. She has one child with chronic hepatitis B. This is her second pregnancy and it has been uneventful thus far. She emigrated from mainland China 1 year ago. Her blood work shows positive hepatitis B surface antigen, negative surface antibody, negative E antibody, hepatitis B DNA level of 300 million, AST of 19, ALT 29, INR of 1, albumin 3.5. What is the next appropriate step? A, initiate tenofovir therapy. B, initiate pegylated interferon alpha 2B therapy. C, watchful waiting, monitoring liver enzymes. D, hepatitis B immune globulin and HBV vaccination for the mother. Or E, screen for HCC. This is a pregnant woman, 34 weeks, third trimester. The very high viral load. All right, let's look at our answers. Oh, 100%. Deep T, it's an easy one for you.
Yeah. Okay, great. Everybody got the right answer here. So basically, if you go back to the question stem, this is a question that is looking at the risk of mother to child transmission of chronic hepatitis B infection. They give you a woman who has emigrated from an endemic region, who already has one child who has chronic hepatitis B, likely transmitted from mother to child, and now is in her second pregnancy. She clearly has a very high viral load, but her liver enzymes are normal, and her synthetic function is normal as well. So in this patient, we know that high viral loads in mom increase the risk of transmission to baby, usually at the time of labor and delivery, and that we have good post-exposure prophylaxis with HBIG and Hep B immunization for the baby within 12 hours of birth. But despite that, transmission of hepatitis B can vary from a low of about 3% with post-exposure prophylaxis to as high as 9 to 10%. And that's usually in patients who have a very high viral load, moms with very high viral loads. So there are guidelines that suggest that for moms in the third trimester, if they have a hepatitis B DNA viral load greater than 200,000, it makes sense to treat them in an effort to reduce this risk of transmission to the baby. And then they're giving you a few different options of what you might treat with. And I think treating with pegylated interferon in a pregnant woman is a no-go. So you could remove that as an option. And then I believe they gave you both tenofovir and, they only gave you tenofovir, but they could have given you entecavir. And here the variation would be that entecavir is based on the old FDA classifications, it's a class C drug, so it's not really recommended in pregnancy, whereas tenofovir is a pregnancy class B drug, where it is more suitable for pregnancy. FDA did change their labeling, so they're not going by the letter grades. It's called the pregnancy, lactation, and labeling rule now, which is a more descriptive form. So, but in terms of pregnancy classifications, it's the old class B drug that you would want to give, which is tenofovir. They also give you the option of Hep B immune globulin and Hep B vaccination for the mom. That would be the appropriate action to take for the infant at the time of birth or soon after birth, but it will not do much for the mom who already has a very high Hep B viral load. And then they gave you screening for HCC, which is kind of a confounder here. Our guidelines would suggest that in a non-cirrhotic woman that you would not start screening until after age 50.
Great. Okay. Yeah, and this is an immune tolerant patient, right? So if she weren't pregnant, we would not necessarily need to treat or consider her for a clinical trial. But all right, this was our first, I think, 100%. So that I think pretty straightforward. All right, the next question. A 23-year-old previously healthy woman presents with new onset abdominal pain, abdominal distension, and lower extremity edema. She has no past medical history. Her only medication is oral contraceptive pills. She takes no supplements. She does not smoke or drink alcohol. Her labs reveal AST 256, ALT 211, alkaline phosphatase 214, total bilirubin 1.3, and INR 1.0. Serologic testing is negative for viral and autoimmune hepatitis. Pregnancy test is negative. On physical exam, her abdomen is distended with a discernible fluid wave. She has 1+ bilateral lower extremity edema. She's alert and oriented ×4 with no asterixis. Which of the following is the next most appropriate test to make the diagnosis? Liver biopsy, hepatic ultrasound with Doppler, hepatic arteriogram, MRCP. Go back to the stem. She's got new ascites, abdominal pain, oral contraceptives, elevated liver tests. So you've got liver biopsy, ultrasound with Doppler, arteriogram, and then MRCP. Okay, take a look at the answers. And our results. Have we got results? Or has no one voted? The poll has frozen, it appears. Okay. Well, I'm going to give you all 100% on this one. I suppose we'll move. The answer here is ultrasound with Doppler. So I always think the answer to any workup for elevated liver test should be an ultrasound with Doppler. So that's specifically to look at the hepatic vasculature and make sure you've got patent, portal vein, hepatic artery, but in this case, the hepatic vein is the problem. So this is a case of Budd-Chiari, and they want us to recognize that that can be, or that is diagnosed by Doppler ultrasound, which will be able to tell you if the hepatic veins are open or not. And the presentation is consistent. She has new ascites and edema, and then is on oral contraceptive pills. So that's your suggestion that it's a thrombotic issue, and most often that is the problem is in the hepatic veins. Often these patients, and the standard is a Doppler ultrasound, but often these patients end up getting some kind of cross-sectional imaging either to confirm, or they're in the ED and they've gotten this cross-sectional imaging instead of the ultrasound. That will still also show problems in the hepatic vein if there is a thrombosis there. The nice thing about cross-sectional imaging is that it gives you a little more information than the Doppler ultrasound just telling you if the hepatic vein is thrombosed. And there, because of the issue being a problem with the drainage of the blood flow from the liver, you can see these pretty typical findings on cross-sectional imaging. So some of these are buzzwords for the board. So caudate lobe hypertrophy, that happens because the caudate has separate venous drainage. So when venous drainage from the right and left lobes are blocked, and the caudate lobe hypertrophies because all the blood is able to go from the caudate straight into the IVC instead of the blocked hepatic veins. And then you'll also see a lot of collateralization, so what that's called spider web appearance, and just generally the perfusion of the liver, the blood's trying to get out in some way around the hepatic vein thromboses, so you see heterogeneous perfusion. So all these are kind of keywords you might see if you're given a case of Budd-Chiari and some kind of imaging that should trigger some thought that, oh, that the problem's in the hepatic vein and we're dealing with a case of new Budd-Chiari syndrome. The other answers were arteriogram, which, the problems in the hepatic vein, not the hepatic artery. MRCP obviously looks at the biliary system, not the vessels. If the answer had been MRI plus MRCP, maybe that would have shown you the diagnosis too, but the option was just MRCP. And a liver biopsy in these cases is not helpful and probably just risky. So not the first step in workup for elevated liver tests. The ultrasound with Doppler should be, and that would show you the diagnosis before you're reaching for a liver biopsy. Okay. Any questions about that? Let's see. Hopefully we can get the poll everywhere up for the next question. Let's see. I think we can move to this one. 62-year-old man is referred for a second opinion regarding primary sclerosing cholangitis. He presented with jaundice and vague abdominal discomfort 3 months prior, and PSC was diagnosed after characteristic features were noted on ERCP. His medical history is otherwise remarkable for coronary artery disease and excisional biopsy of an enlarged supraclavicular lymph node 1 year ago with nonspecific findings on pathology. He is up to date with cancer screening and had an unremarkable colonoscopy 2 years ago. His physical examination is remarkable for jaundice. His labs show hemoglobin 13.4, white count of 7.5, ESR 62, AST 35, ALT 39, alk-phos of 55, total bilirubin 5.4, and a CA 19.9 of 18. You recommend MRCP, which reveals stricturing of the extrahepatic common bile duct, a prominent distal bile duct stricture, and enlargement of the pancreas. What is the next best step in evaluation of this patient? Oh, it looks like our polls are working again. So check the serum IgG4 level, ERCP with biliary brushings for cytology and FISH, endoscopic ultrasound to assess the pancreatic head and distal common bile duct, PET scan, and refer for hepaticojejunostomy. Oh, it looks like it's working, but apparently it's not exactly working yet. So you could put it, there's a chat function if you want to put your answers in there, or we will reveal the answer in about 5 to 10 seconds. Oh, now it's working. Okay, let's give it a try. I'm getting live updates. Can we give the poll everywhere a try? And go to see if we can go. We've got some answers flowing in. Excellent. All right, Taprana, I feel like this is a new question, or like one of, a recent, yeah.
Oh, wow. Okay, so a little bit split between these answer choices. So we'll talk about this in detail then. So this patient definitely has a sclerosing cholangitis, right? So the cholestatic abnormalities in their liver test, the alkaline phosphatase is high, the MRCP shows that there's clear stricturing in the bile duct. I think that there's two things that are sort of red flags for whether or not this is a true PSC in this case. The first is that there's an abnormality in the pancreas, the enlargement of the pancreas. And the second is that this patient has a history of lymphadenopathy, so some sort of some potentially another process that was going on. So remember that primary sclerosing cholangitis, in order to be diagnosed, you really have to make sure that there's not a second etiology. And it is recommended that in all patients with a primary sclerosing cholangitis that you do check IgG4 levels, because you'll detect it in a significant proportion of patients too. So the presence of the pancreas, the history of lymphadenopathy, both sort of suggest that it could be an IgG4 related disease. Remember, this is a systemic disease that has, it's sort of characterized by pretty extensive IgG4 positive plasma cell infiltration and T cell infiltration, which causes fibrotic lesions and this obliterative phlebitis. So it can affect the pancreas, affects the bile ducts, the gallbladder, salivary glands, the retroperitoneum, the lung, the kidney, and very frequently we see lymphadenopathy associated with it. It's unfortunate that the excisional biopsy, the lymph node for this patient was non-diagnostic previously. Remember that it tends to occur in older men as well. And he sort of fits the demographic of it as well. So the other answer choices are not necessarily things that you wouldn't do after. But remember, this is asking us what the next best step is in evaluation. So in anybody, remember that you're considering a sclerosing cholangitis diagnosis for, you need to check an IgG4 level. And especially in someone that has potential other clues that this could be another secondary cause of a sclerosing cholangitis. Remember, the treatment for this is very different than it would be for PSC. IgG4 associated cholangiopathy is very steroid responsive. So this patient would benefit from treatment very differently than if you were going to diagnose with PSC to begin with. Not to say that eventually you might not need to do an ERCP to take a look at the bile duct stricture. You might need to do an EUS to take a look at the pancreatic head. But the next best thing in this case would be to check a serum IgG4 level, the least invasive test possible.
Yeah, Aparna, I feel like this is a relatively recent addition to the boards, because I think when I took boards, I don't think this would have been fair game, or IgG4 disease may not have been fair game, but now it's pretty established.
Yeah, I think I honestly I can't tell you when it would have been added to the board. That IgG4 related disease has been around for a fair amount of time, and we've known about IgG4 associated cholangiopathy for a very long time as well. I think that it's very clear now that when you are thinking about the diagnosis of PSC, that you have to check a serum IgG4 level. So that has that is definitely guideline recommended now.
Yeah, seems pretty established now, so we'll see more of it, I think. Okay, next question. So 27-year-old man with history of AML underwent hematopoietic stem cell transplant 18 days ago. He now complains of abdominal distension and an 11-pound weight gain, right upper quadrant pain, and jaundice. His exam is remarkable for moderate right upper quadrant tenderness on palpation and abdominal distension with shifting dullness and a fluid wave. Liver function tests show AST 135, ALT 170, alk phos of 120, bilirubin of 4.8, albumin 3.0, INR 1. Right upper quadrant ultrasound reveals significant ascites and an enlarged liver. Doppler study showed normal flow in the hepatic and portal veins. What is the most following, or which of the following is the most likely diagnosis in this patient? Acute cellular rejection, hepatosplenic candidiasis, sinusoidal obstruction syndrome, vanishing bile duct syndrome, or acute viral hepatitis. And options are acute cellular rejection, hepatosplenic candidiasis, sinusoidal obstruction syndrome, Banner string bile duct syndrome, or acute viral hepatitis. So we'll take a look at our answers here. 100%, excellent. So this is my topic. So I hope that means that everyone got it. This is a pretty. We can go back to the stem. You really, I mean, the only time hematopoietic stem cell transplant is going to show up on your GI boards is probably sinusoidal obstruction syndrome. So you really only have to read the first line and look at the history. They'll give you pretty much the whole consistent history of ascites, weight gain, jaundice. These are all diagnostic criteria for sinusoidal obstruction syndrome, which occurs in the first 2 to 3 weeks after a stem cell transplant due to the myeloablative therapy. There are other rare situations with other medications in patients who haven't gotten the stem cell transplant, but I think at least on the GI and liver boards, they've always given me a history of stem cell transplant. So that's the trigger here. And I think 100% of people answered correctly. So I think that's not, that's a good thing. You know, it's a hard thing to it's a hard entity to treat, well, and also recognize. It's not always this clear cut on the, as on boards. In real life, there's so many other things that could be going on with these patients who've just gotten stem cell transplants, including you know, some of these answer choices that involve infection, even maybe viral hepatitis, medication-related effects. But this is what we're gonna see on boards. The treatment, really, hematologists have been pretty good at, you know, choosing maybe a less toxic myeloablative regimen. And then in the peri-transplant phase, ursodiol seems to help. And then defibrotide sometimes comes up as a possible, it's FDA approved for treatment of this. So that is once you've made the diagnosis, and unfortunately, if you've developed SOS, defibrotide can be a treatment option. Usually on boards, they'll just have you like this, recognize the entity, not necessarily treat it. Okay, we'll move on. A 63-year-old man underwent deceased donor liver transplant 8 months ago for alcohol-induced cirrhosis. His liver enzymes normalized soon after transplant and remained normal. His liver enzymes have been repeatedly elevated over the past week with AST 180, ALT 212, alk phos of 198, normal total bilirubin, and normal INR. Tacrolimus level was most recently 2, and they tell you your target level is 5 to 7. He is feeling reasonably well, but does note some mild fatigue. He takes no other medications besides his tacrolimus. He takes no supplements. He is not drinking alcohol. Ultrasound with Doppler of the liver is normal. Serum CMV PCR is undetectable. You suspect acute cellular rejection given his low tacrolimus level. You obtain a liver biopsy. Which of the following features would be expected on his liver biopsy? Ductopenia and cholestasis, intranuclear inclusions with prominent mononuclear infiltrate, ductulitis and endotheliitis, or multinucleate hepatocytes. Go back to the all right. So let's take a look at our answers here. All right. Oh, this is quite a mix, so this is a good one to go over. So finally, Tammy, I think you're up.
I mean, I didn't do a good job explaining it in my section.
No.
Or we just haven't gotten to that yet. This is a great question, because it basically, you can get the whole history from the vignette, which is nice and really kind of helps it, kind of show where you should be leaning towards. And so basically, you can get everything from the history. I think the key things here is not that it's not asking us what do we need to do to make the diagnosis. That's obviously you're doing the liver biopsy, but what are we expecting to find? And so I think the key things is to look at is the patient is asymptomatic, right? This is, and then what you also want to break it down into is kind of what we do with anyone who walks into your office with abnormal liver enzymes, or what is the source of that? And so you would do just like what you do to any patient. Are there any new medications? Are you taking your medications? Are there any supplements, any hepatotoxins? And it gives us all that information in there. And then when we also want to do looking at any kind of viral infections, right? It's giving us that information as well. And particularly when we're talking about liver transplant, we want to know the CMV, right? If that's, and they did check that for you. And then of course, the last thing we want to do is to make sure that you check the ultrasound and there's no anatomical abnormality. So it kind of gives you all this history. And so it looks like this man is also early after transplant. He's only been transplanted about 8 months ago. But we do see that he's what looks like he's under immunosuppressed. So this is really leading you to acute cellular rejection. And so when we have acute cellular rejection, we're going to see dactylitis and endotheliitis. I think it's a good thing that people did not get swayed by looking for findings of viral infection, right? And that is both B and D, the intranuclear inclusions and the multinucleated hepatocytes. You can see that in viral infections like CMV and HSV. But the key thing is kind of delineating between ductopenia and cholestasis and the dactylitis and endotheliitis. Those are more, C is a more acute reaction. And ductopenia and cholestasis is what you see with chronic rejection. So if you see someone who's, maybe more than just a few months out, maybe a year or even 2, if they're either off their immunosuppression or if they're chronically under immunosuppressed, which this man isn't at this point in time, then you're really going to have that bile duct loss and the development of cholestasis. So the answer is C, dactylitis and endotheliitis.
Cool. And you went over this, you've got this bonus slide.
And so the treatment of acute cellular rejection is just, Solu-Medrol, increasing the immunosuppression, and sometimes even in severe cases, ATG. The bad thing about chronic rejection is that we don't really have good treatments for that. And I also did fail to mention, it's always good to realize, again, acute cellular rejection, someone's going to be asymptomatic, and all the liver enzymes can be elevated, right? It can be your alk-Phos, your GGT, your AST, and your ALT. So it's not like one enzyme is more particularly elevated than another. Versus in your chronic rejection, you're going to probably see more of an alk-Phos, GGT, and total bilirubin elevation, and that's just reflective of your, ductopenia.
Great, thank you. Okay. We'll move on. I think we're making good time, so we'll move to the next one. A 45-year-old man with chronic alcohol and hepatitis C, well-compensated cirrhosis, presents with a liver ultrasound report in hand that notes a 1.6 centimeter liver lesion in the left lobe of the liver. Which of the following is the next appropriate step? Repeat ultrasound in 6 months to assess for growth, refer to liver transplantation, obtain a triphasic CT, obtain a liver biopsy, or refer for surgical resection. This is a 1.6 centimeter liver lesion, compensated cirrhosis. All right. We can, it's a short stem. Yeah, we can look at the answers here. Oh, okay. Jump to responses. All right, Renu, this is yours, our HCC expert. Renu, are you? Yes. Oh, you're muted, I think, still. There we go.
Yeah, there you go. Thank you. Looks like there is some people have chosen A, so that's good, so that we can discuss. So this is a question on diagnosis of liver lesions. So this is a patient who has a 1.6 centimeter liver lesion on an ultrasound. I think what is important to realize is that the patient has cirrhosis, and in all patients with cirrhosis, all liver lesions should be suspected for HCC until proven otherwise. So now we are worried about a liver cancer lesion here. So if I like to go through the process of elimination when I look at my choices, which I think pretty much everyone here has done. Without knowing the diagnosis of the lesion, we are not going to refer for treatment. So transplantation and resection will not be the right choice. So now you're left with either a biopsy, a CT scan, or a repeat an ultrasound. So I'll just go by elimination. So liver biopsy can be useful in HCC in specific rare circumstances where all other imaging modalities do not lead to the diagnosis and there are indeterminate lesions. But in general, we avoid it because, first of all, the diagnosis can be made on other triphasic imaging modality, which I'll discuss next. And second, there are some small risk associated with liver biopsy, like either bleeding from a biopsy site, or even more dreaded complication would be seeding of the cancer through the needle track, which can then lead to cancer recurrence after treatment. So we try to avoid biopsy whenever we can. The remaining two options are either repeating an ultrasound or ordering a triphasic CT. For a lesion that is greater than 1 centimeter in size, either a triphasic CT or a triphasic MRI are really good at helping us arrive at a definitive diagnosis. So since this lesion is 1.6 centimeters, we don't have to wait and repeat an ultrasound. We can go for a more definitive diagnostic test here. So that will lead us to the triphasic CT. And if you think about why triphasic CT, because if they have another option of, say, non-contrast CT, you want to make sure that you're choosing a tri or a quad-phased cross-sectional imaging, because the diagnostic criteria are based on these enhancement patterns. And to make a diagnosis of HCC, you need to have enhancement on the arterial phase and washout on the delayed phase. And depending on the size, you would also need the presence of a pseudocapsule. So whenever you have these questions which are coming at diagnosing HCC, remember the imaging can make the diagnosis without a need for biopsy, but you do need the triphasic CT or MRI, and you need to have those classic imaging characteristics. That's what the question is testing. Yeah.
All right, thank you. We're going to revisit this guy with the 1.6 centimeter lesion in a little bit. So I think we're going to move to a different topic here. Now, this is a long stem. 60-year-old man, deceased donor liver transplant 2 months ago for hepatitis C, presents for urgent clinical evaluation. His hepatitis C was treated and cured pre-transplant. His immediate post-liver transplant course was uneventful. He received 4 doses of anti-thymocyte globulin induction. His liver enzymes and liver function normalized soon post-transplant as anticipated. He presents now with a 3-day history of fevers, persistent diarrhea, and a maculopapular rash on his chest, back, hands, arms, and legs. His current medications include tacrolimus and mycophenolate mofetil for immunosuppression. He also takes sulfamethoxazole, trimethoprim, because we're not allowed to do brand names, valganciclovir, and fluconazole for routine infection prophylaxis post-liver transplant. He states he is feeling very poorly and he appears clinically unwell on exam with a blood pressure of 93/58. Lab data reveals AST 19, ALT 22, alkaline phosphatase of 101, total bilirubin 0.7, albumin 3.6, and INR 0.9. Tacrolimus level is 7, which appears to be within your target, and he has developed new leukopenia and anemia with a white blood cell count of 1 and hematocrit of 19. What is the most likely diagnosis? Acute cellular rejection, CMV infection, small for size syndrome, or graft versus host disease? Let's go back again here. Long stem. So we've got acute cellular rejection, CMV, small for size, or graft versus host disease. So let's take a look at the answers. A few responses. Oh, 50-50. Good. It's a transplant question, so this is for you, Tammy.
Okay, thanks. So I'm just going to say I thought this question was a little bit big for the GI boards. I think that this would even be, a surprise on the transplant boards. But we'll just go through it. So we'll go through the things that it looks like, and this is kind of bouncing off the previous question. What are the things we're looking for in the history, right? They give us a very extensive history. The key thing, it looks like it's not as Hep C because he was already treated before transplant. So let's just look at the answers and say what it isn't, and then we can talk about what it is and why. So you have normal liver enzymes. That's a key marker here. So we would say, and he's therapeutic as far as his chakra level. So we're going to say no on the acute cellular rejection. We do note that he is leukopenic and has a low hematocrit as well. So we can see that in CMV infection as well. But this gentleman also is on his bowel site, right? So he is on appropriate prophylaxis. So again, very unlikely. As far as small for size syndrome, you're really going to see problems of delayed graft function, actually. You might see some elevated bilirubin, but you're also going to still have problems with like ascites and volume management, because again, it's just this liver that was maybe too small for the patient it was going into, so it takes a while to regenerate. So really that's an unlikely one. So we're left with graft versus host disease, which is very rare in liver transplant. Its estimated incidence is 0.5 to 2%. So it's very rare. However, it has a very high mortality. So it's very important to make the diagnosis. It can present in the first 1 to 8 weeks after transplant, and this is kind of where we see our patient is. And the key things is the presentation of the maculopapular rash, which you could say, oh, is it a drug reaction, right? And everybody always likes to blame Bactrim, but he also has the diarrhea and the fever. So that really is really swaying us to GVHD. So again, looking at the history, your key things are going to be, that's the only thing that's going to give you the maculopapular rash, diarrhea, fevers this early after transplant, when everything else is, going well and he's on all his appropriate medications. Does that make sense?
Yes. Thanks, Tammy.
Still an unfair question, but just look for maculopapular rash.
Yeah. All right. So we've got a couple more. Oh, these keep going. A few more. We'll still be on time. A 38-year-old G2P1 female with a past medical history of obesity, dyslipidemia, and hypertension, and non-alcoholic fatty liver disease presents with right upper quadrant pain, nausea, and vomiting at 33 weeks gestation. Ultrasound shows cholelithiasis without gallbladder wall thickening or pericholecystic fluid. CBD is dilated to 7 millimeters with a suspected stone in the distal duct. Labs show AST 40, ALT 35, total bilirubin 1.8, alkaline phosphatase 210. Which of the following is the next best step in management? Start ursodeoxycholic acid at 10 to 15 mg per kg, ERCP, open cholecystectomy, supportive care, laparoscopic cholecystectomy. She is 33 weeks gestation with a suspected stone in the distal duct. Let's look at our answers here. Okay. Oh, little bit of a mix here. So deep D, this is a pregnancy question.
Yeah, great, thanks. So yeah, a little bit of two different choices. Mainly everybody chose ERCP, some people chose supportive care. So like Allison said, this is a question that's getting at choledocholithiasis in a pregnant woman and what the best management strategy is here. We know that gallstones are common in pregnant women. By the end of the pregnancy, up to 8 to 10% of patients will have gallstone formation, and that's due to increased cholesterol saturation of the bile, increased lithogenicity of the bile, and impaired motility and gallbladder emptying due to the changes in hormones. That being said, ERCP is considered to be a safe procedure, and it is the modality of choice to treat choledocholithiasis. So if you go back to the answer choices, they give you cholecystectomy as possible answer or ERCP. And I think between these two, for choledocholithiasis, ERCP would be the preferred management strategy, as there's no evidence of cholecystitis here. And then the question becomes, is ERCP safe in pregnancy, or do you manage more conservatively with supportive care or starting ursodeoxycholic acid? And the answer here is that ERCP is safe in pregnancy. There are certain things that you have to be careful with in terms of shielding. And ideally, if you have the ability to hold off on an ERCP in the first trimester or in the third trimester, it's better because there's an increased risk of miscarriage earlier on and an increased risk of preterm labor later on in the pregnancy. So the second trimester is your sweet spot. But if an ERCP needs to be done, it can be done safely by reducing the fluoroscopic time, appropriate shielding and positioning of the patient. So therefore, ERCP is the right answer here. Supportive care is not the right answer. And ursodeoxycholic acid, although it may decrease the stone size and dissolve the stones, that takes months, and she has a stone stuck now, and she's symptomatic. So ERCP would be the right answer.
Cool. Thanks. And I think you've got another slide here.
Yeah, and I think I kind of went through this.
Yeah.
Again, there's so many changes, hormonal changes in pregnancy that increase your risk for developing gallstones, increased cholesterol saturation, impaired gallbladder emptying. So the rate of gallstone formation goes up throughout the course of pregnancy, but complications related to gallstones remains low. So if it's just biliary colic, you might consider supportive care, but if you've got evidence of a stone obstructing, then ERCP would be the choice. Lap cholecystectomy is also considered to be safe in pregnancy, ideally in the second trimester.
Great, thank you. All right, moving right along here. We're back to liver lesion. So best approach to management of a patient with cirrhosis, child A, normal bilirubin, no varices on EGD, who has a 1.9 centimeter hepatoma on the edge of the right lobe. Oh, then we've got the stem and the answers on this. This is nice when this happens. So you've got best approach to management, liver transplantation, tumor resection, repeat study in 6 months, transcatheter arterial chemoembolization, or radiofrequency ablation. All right. So I've been waiting for one more response. Okay, we can move. We can look at the responses. Oh, we've got a couple more. All right. It's the worst when they're 1.9 centimeters. Okay, Renew, you're up.
Yeah, hi. So I see that in this study, in this question, no one chose repeat study in 6 months. That's great. It's the easiest elimination because in the STEM, they already told you that it is a diagnosed hepatoma. So once you've diagnosed HCC, we are going to now take action and not be waiting. So now we have 4 treatment options here: transplantation, resection, TACE, and ablation. I would look at first staging the patient to then decide which treatment is optimal. So this patient has a single tumor that's lesser than 2 centimeters. So he has early stage HCC or very early HCC. So I would definitely go for a curative therapeutic option. So then at that point, I would eliminate TACE. TACE is considered to prolong or to bridge to different therapies, but not considered curative by itself. So now you have 2 surgical options: transplantation, resection, or ablation. So I would think about whether this patient needs a transplantation, and the information they're giving us is he's cirrhosis, but he's Child-Pugh class A, so well compensated. They don't mention that the patient has any decompensating events. They do make a point to say that there are no viruses on EGD. So this patient potentially does not need a transplantation. They haven't mentioned a MELD score, but given the information here, it's likely to be less than 15. So then we are looking at 2 other options: resection and ablation. Both can be considered curative for small lesions. There are no head-to-head large randomized control trials comparing the two for small lesions. But in different meta-analysis and studies, they have found them to be equivalent. And in these cases, I consider the location and, of course, patient preference as big factors in making the decision. And they do give us something about the location here. They talk about how it's in the edge of the right lobe. When the tumor is on the edge, there are two factors here. One is usually these are easier to resect since they are in the edge. They should probably be able to remove a small area of the liver. And for ablation, lesions that are closer to the surface of the capsule of the liver, or lesions closer to large vessels, are more difficult and challenging to ablate, because when they are close to big vessels, you can have the heat sink effect, where the heat you're now delivering through the ablation can be dissipated via the flowing blood. And so these lesions close to blood vessels, you might not get the whole lesion. And then the lesions on the edge or close to the capsule, you don't have enough of a area through which your ablation needle can first traverse before hitting the lesion. So you're going to straight away hit the lesion. You can either potentially not get the entire lesion or cause complications due to rupture. So, so in this well-compensated patient who has a single early lesion, resection would have pretty high chances of curing the patient of the tumor. So the resection would be the right option here. If the STEM, and I presume in general the STEM will be longer in most of the board questions, probably give you more information about the cirrhosis for you to make a decision between transplantation and resection. I think they've given you 1.9 centimeters because you need to be 2 centimeters to meet Milan criteria for liver transplantation. So a patient like this will face the option of either undergoing a resection now, especially if he's well compensated, that will be a good option, versus waiting for a few months while we monitor this lesion, which is what we have to do if the patient was decompensated. And in those cases, there is always risk of hyperprogression or rapid progression during that waiting time. So if all else being equal, if the patient's well compensated and is able to undergo surgery, this would be a very reasonable option here. So the right answer should be B, tumor resection.
Great, thank you.
Thank you.
All right, we'll move along. Yeah, so 66-year-old woman with a history of heart failure has been complaining with abdominal discomfort. The ultrasound of liver shows a nodular liver. Portal pressure measurements show a hepatic venous gradient of 10. Which of the following is the next best step? Perform an EGD, begin a transplant evaluation, refer to cardiology to improve cardiac function, start a non-selective beta blocker, or start a PPI. So we got a heart failure, nodular liver, gradient of 10, and your options: EGD, transplant, verticardiology, beta blocker, or PPI. So look at let's look at our options here. Yep, got a few responses. 50-50. Okay, that's good. It's always nice that there's something to debate. So Amanda, this is yours.
All right, so it's a pretty short question stem, but basically you have a lady who has heart failure, and then they have what appears to be, not what appears, what is portal hypertension, which is the pressure gradient of 10. So just as a reminder that the definition of portal hypertension is a gradient greater than 5 millimeters of mercury. So the little bit about heart failure that was thrown in a question stem, I think to throw people off, is because heart failure can also cause portal hypertension. And so they wanted to see if you could be swayed by that to simply send it off to cardiology. So one important note is, and Allison, can you go to the next slide real quick? Yeah, is that in patients who have heart failure, even though they can have portal hypertension, the hepatic venous pressure gradient is typically normal, which is the case in patients who have a post-hepatic cause of portal hypertension, which is essentially right heart failure, pulmonary hypertension. So in this particular patient, because they do have a pressure gradient, then you're looking more at the other causes, such as, for instance, cirrhosis. So perhaps in this patient, the heart failure led to cirrhosis. So the appropriate answer for this patient is to actually perform an EGD for variceal screening. Not enough information in the question stem to warrant a transplant evaluation, and perhaps you'll use a non-selective beta blocker in the future if you do find varices, but it's not the best first choice for this particular question.
Great, thank you. I like this slide. I'm going to steal it from my talk next year. Okay. We move. Okay. So the next question: 50-year-old woman, history of hepatitis C cirrhosis, presents to the ED with a complaint of 2 days of right upper quadrant pain. She has no history of ascites, but has grade 2 varices on EGD 1 year ago, currently being treated with nadolol. Her vital signs: pulse of 67, blood pressure 125/70, respiratory rate of 14, O2 sat 98%. Her exam was remarkable for moderate right upper quadrant tenderness on palpation. Her white count is 11, hemoglobin 11.1, platelets 102, AST 95, ALT 130, alkalis 102, total bilirubin 1.2, albumin 2.9, INR 1.3. Right upper quadrant ultrasound revealed normal gallbladder, CPT 3 millimeters, liver small size, nodular contour, no liver masses. Doppler study showed normal flow in the hepatic veins and a thrombus in the main portal vein with no evidence of collateralization and no arterial pulsations within the clot. And the serum AFP level is normal. Okay. Oh, this one is a little, we'll go through this quickly. What is the best next step in the management of this patient? Begin therapy with a NOAC, perform ligation of her varices, then anticoagulate, continue to observe her or recheck a Doppler study in 3 months, refer her for urgent liver transplant, or begin DAA therapy for her hepatitis C infection. All right, so we've got a few options. This looks like a thrombus in the main portal vein, and our options are begin a NOAC, ligate her varices, then anticoagulate, observe and recheck a Doppler study, refer for transplant, or treat her hepatitis C. Okay, we'll go to the answer choices. Okay, sure. 100%. So Amanda, we can do this one. The board answer
Okay.
quickly.
So just a real quick note about portal vein thrombus is that it's pretty common in patients with cirrhosis. So even when the INR level may be quite high, because they can also have a protein C and S deficiency, which are anticoagulants. So in these patients, they might actually be hypercoagulable. So anyhow, the question stem tells us that this patient has a portal vein thrombus. And the studies have shown that using systemic anticoagulation can be helpful in leading to recanalization and also just improved outcomes when you use anticoagulation. So for the purpose of this question stem, the answer is B, as everyone chose, to perform ligation of the varices and anticoagulate. Just to point out that the New York guidelines does say that for a patient who needs primary prophylaxis, that the recommendation is actually to start them on a beta blocker and then ban them only if they are intolerant or contraindicated to a beta blocker. And I think that's partly just to not delay the initiation of anticoagulation.
Okay, good. Well, everyone got the board answer to this correct. So great. I think the other ones, NOAC, there's no data for, and the others might be right, but that they want you to ligate first here. Okay, we'll move to the next one. We've just got a couple more. So 56-year-old woman with autoimmune hepatitis, related cirrhosis, history of hepatic encephalopathy and ascites. She is brought to the emergency department by her daughter for being sluggish for the past few days. Her daughter increased lactulose frequency, but the patient did not improve despite having had 10 bowel movements a day for 2 days. Her medications include spironolactone, furosemide, and lactulose. On exam, her vitals are stable and she is alert and oriented to place in person without asterixis. What is the next best step in management of this patient? Admit her for more testing to rule out electrolyte abnormalities and infection, add rifaximin and zinc, obtain MRI of brain, obtain blood ammonia levels, refer for psychometric testing. All right, look at our answer choices here. We got quite a few. Oh, 100% again. That's great. Okay, Amanda, this will be quick then.
So everyone knows it already. Just to review real quick, the most common cause of HE is almost always actually medication noncompliance. But in this particular patient, she's already taking enough lactulose and having more than enough bowel movements. So the investigation should be on other causes of hepatic encephalopathy. So that can be anything from infection, dehydration, electrolyte disturbances, GI bleeding, a neurologic event like a stroke, toxins like alcohol or any other medication. So those are all the things you want to look for, which are all included in answer A. Just a quick note, we don't use ammonia levels for diagnosis or management in these patients. And although brain imaging may be helpful in this particular patient with a normal exam, we would probably opt for A before we would go to any type of brain imaging.
Okay, great. All right. Here we go. Here's our guy with the 1.6 centimeter lesion who came back. So 45-year-old man, chronic alcohol hep C, well compensated cirrhosis, presents with liver ultrasound report in hand that notes a 1.6 centimeter liver lesion in the left lobe of the liver. The patient now returns to discuss the results of a triphasic liver CT that you ordered. Now the lesion measures 2.7 centimeters and enhances on arterial phase and washes out on delayed images, and a rim of capsule is visible around the tumor. What is the next best step in management? Measure serum AFP, refer for tumor biopsy, refer for liver transplantation, refer for surgical resection, or refer for ablative therapy and liver transplant evaluation. I wonder how long it took him to get the CT. All right, that's 2.7 centimeters. We'll take a look at the responses. Oh, it's a mix again, these cancer questions. Okay, that's good. It'll be good to discuss. So Renu.
Yeah, I like it when it's mixed. So in this patient, so it's the same patient who had 1.6 centimeters, and now the triphasic CT is showing 2.7. To briefly discuss that point, in general, the tumor doubling time for HCC is around 6 months, which is why we opt for imaging these patients every 6 months. Of course, there is variation, and there are slow and rapid progressors. So it is possible that he had a more aggressive HCC, which has been growing faster than median. It is also possible that the imaging, the ultrasound was not accurate in the size detection. So MRI or a CT scan are better at detecting some of the lesions, especially if the location is in the caudate or somewhere in the posterior parts of the liver. And if the liver is very fatty, or if the patient is obese, or if there are intervening gas bowel, there are different reasons why an ultrasound could have underestimated the size of the lesion. So I always remind my patients not to compare apples and oranges, and not try to look at these different kinds of modalities and then wonder for these when there are a few millimeter differences. But what we have now is a lesion that is larger than 2 centimeters, and now it's meeting diagnostic criteria for HCC. It's arterially enhancing and washing out and greater than 2 centimeters. So we have a confirmed case of a patient with HCC, also has underlying cirrhosis. So you're right in ruling out the need for a tumor biopsy because the patient is meeting radiologic diagnostic criteria. Now, measure serum alpha-fetoprotein. It's not a wrong answer. It will help in prognosis. It will help in tracking the lesion. But the question is, what is the next best step in the management? And I think once you have a diagnosis of HCC, like I mentioned before, you want to go ahead and try to secure a more definitive treatment plan, geared towards curing the disease. So if there are better options than measuring serum AFP, I would not choose that in this STEM. So that leads us to, I see that people eliminated resection. Happy to see that. Yes, it is a single lesion, potentially resectable, but the patient has portal hypertension. How do we know that? They mentioned here the platelet count of 85,000. So in general, we use a cutoff of 100,000, but we do look for multiple other, factors. We see if they have varices, do they have splenomegaly, intra-abdominal varices on imaging, and platelet count to assess the degree of portal hypertension. Because once you have portal hypertension, resection can be associated with high rate of complications and bleeding. So now you have a transplantation or a therapy along with referral for transplantation. And the correct answer here is refer for ablation and liver transplant evaluation. The reason is the process of liver transplant evaluation, getting the patient on the list and getting the patient eventually transplanted can take months to years, especially in different regions of the country. It's different, and especially in California, it's true. So the guidelines recommend offering bridging therapies to maintain the tumor burden within Milan criteria until the patient can be eligible for liver transplantation. So the right option would be to do both bridging local regional therapy while you refer and get them ready for liver transplantation. So there's a bonus slide here on transplantation for HCC. So in patients who have early stage HCC, BCLC class A, who have cirrhosis, and especially if they're decompensated, then transplantation is considered the best curative option for both their cirrhosis and their HCC. This can be associated with a 5-year survival upwards of 70%. Recurrence is still possible. Usually the recurrence rate is around 10%. We do screen for these possible recurrence post liver transplant. And I think in my talk, I do go over some of the criteria for who is considered transplant candidate based on size and number of lesions. I don't know, Allison, do you have to click again? I think it showed up.
Yes, I think one more click.
Yeah, so you don't have to remember these numbers. I think those might be more important for transplant boards. But in general, you could try to remember Milan criteria, which is single lesion less than 5 centimeters or up to 3 lesions. All lesions should be less than 3 centimeters. If you're within that size and number range, then you'll be considered eligible for transplant. We do have more expanded criteria where we can try to downsize the patient and then offer transplant. I'm pretty confident those will be outside the limits of the board. But Milan criteria is something simple and easy to remember. And that's the size when you're eligible for liver transplantation. Thank you.
You've got a question in the Q&A box, or what is the about HCC surveillance after transplant? It's a little different setting, but what is the frequency of surveillance that we do for after transplant for HCC?
Yeah, that's a good question. And to be honest, it is not set in stone. The guidelines for pre-transplant or the guidelines for evaluation HCC surveillance in a cirrhotic, we do have international guidelines. Most societies recommend every 6 months. But post-transplant, we take an approach of risk stratification. We look at multiple factors which increase their risk for recurrence. For instance, we look at the explant. If there is microvascular invasion in the explant or extensive tumor burden in the explant, we know that they are at higher risk for recurrence. So those kinds of patients, we do more frequent HCC surveillance in the first 2 years. In my practice, depending on some of the criteria that I use, I survey them every 3 months in the first 2 years. And after that, for the high-risk patients, after that, go every 6 months for another couple of years. The risk of recurrence is highest in the first 2 years. So that is when we have to decide whether it's every 3 months or 6 months. And we use a risk stratified approach for that. It's usually 3 to 6 months.
Thanks, Rania.
Thank you.
All right, we've got one more. Oh, this one. Okay, sure, we can do this. Which of the following is a risk factor for ischemic cholangiopathy? Primary biliary cholangitis, liver transplantation, Budd-Chiari syndrome, autoimmune hepatitis, or acetaminophen toxicity. Let's see, one more coming. Or we can move to the results here. Oh, there's no, there we go. Okay, well, if you 100%, wait, so Tammy, was this the question that you, I think I had a different version of the questions in the.
I have, I do too. There's like, I haven't seen this one and there was 2 other ones, but I'll make it quick and dirty. How's that? Is this the last one? Okay, I haven't seen this. I'm hoping, I agree with you, liver transplantation. When I think this harkens to one of the last slides on my talk about complications after liver transplant. And so if we have, for some reason, if we don't have adequate hepatic arterial supply, then we're going to get that ischemic cholangiopathy because the bile ducts are served solely from the hepatic artery flow. So we'll just kind of like put that there for the risk of ischemic cholangiopathy, right? None of these other ones are really going to cause that. And then there were 2 other questions that I thought that were helpful. One of them is, again, you will get a question on HPS. You'll have a patient who comes in with cirrhosis, portal hypertension, maybe they have a low MELD, 15 to 20, but they're hypoxic, okay? And so your differential is gonna be HPS or hepatopulmonary. I'm sorry, that's the same thing, hepatopulmonary or portopulmonary. Again, your difference, your portopulmonary hypertension is going to be an elevated RVSP on echocardiogram. For your HPS, they're going to ask you, how do you make that diagnosis? And you're going to make it with the cardiac echo with a bubble study showing left-sided bubbles, but after the 4th, anywhere from the 4th to 6th beat, okay? They may try to confuse you and say, oh, you had some immediate bubbles, but again, these are late bubbles. These are bubbles that are going through the pulmonary vascular system. They're not absorbed, so they're going back into the left side of the heart, if that makes sense. Okay, they're not going to try, they might say, oh, you get a CT scan. CT scan is not diagnostic, it's not specific. They're going to ask you HPS about late bubbles on echo. And then I think there was one last question too. It was like a super easy one. Let's see, hold on.
It's about contraindication.
Yeah, contraindication to transplant. That was like, there was a slide on that. So basically, contraindication for a liver transplant in this particular slide was hepatocellular carcinoma with macroscopic invasion of the hepatic vein, right? So that would be a reason if we have macroscopic invasion, that's considered metastatic in my book. So we're not going to make any big change. I mean, we're not going to be making life impacts in someone who has kind of metastatic liver cancer. So that is a contraindication. Just in review, remember HIV, we can transplant, we cannot transplant someone who has AIDS. And portopulmonary hypertension, if you have a mean PA pressure of greater than 35, we cannot transplant them. We can if we can get it less than 35. And again, an absolute contraindication to liver transplant is if someone has portopulmonary hypertension with a mean PA pressure greater than 50. That's like kind of high risk of death on the table. Okay, so that was a little summary of the questions that didn't make it on.
Thanks, Tammy. All right, thanks everyone for sticking through the whole thing with us. And so we'll wrap up this session for today.
Yep, and we thank you to all the panelists. You did a great job, and we're so grateful for having you here today. We'll see everyone again tomorrow morning at 8 a.m. for lower GI and small bowel review. Okay. Thanks, everyone. Bye.